All right, welcome everyone. My name is Jessica Gibson, and I'm a professor of community health sciences at the UCLA Fielding School of Public Health and director of UCLA's Bixby Center to Advance Sexual and Reproductive Health Equity. Thank you so much for joining us today. So it's my role today to welcome you to the Center for Reproductive Science, Health, and Education's Distinguished Speaker Series featuring California's Surgeon General, Dr. Diana Ramos. So the Bixby Center is a proud co-sponsor of this event, and I would like to take this moment to recognize and thank our other co-sponsors, including the UCLA Department of OBGYN, the UCLA Center for the Study of Women, Barbara Streisand Center, thank you, the UCLA Center on Reproductive Health, Law, and Policy, and the UCLA Department of Molecular Cell and Developmental Biology. Achieving optimal reproductive, maternal, and child health is essential for building healthy families, communities, and society. Realizing and sustaining this goal is important now more than ever, given this time of intense and immense change. To meet this moment, the Bixby Center, together with the CRSHE, the Center for the Study of Women, and the Center for Reproductive Health, Law, and Policy, have established the Network for Reproductive Health and Gender Equity at UCLA. This one-of-a-kind, cross-campus collaborative is designed to leverage our distinct expertise to further reproductive health equity through partnerships in education and outreach. We hope you will join us for future joint activities. So it's now my honor and privilege to welcome to the stage the Dean of Life Sciences, Tracy Johnson. Dean Johnson is the Keith and Cecilia Terasaki Presidential Endowed Chair in Life Sciences and a professor of the Howard Hughes Medical Institute. She will be introducing the CRSHE and our distinguished speaker. Thank you, Dean Johnson.
Thank you so much for that introduction. As Jessica mentioned, I'm Tracy Johnson, and I'm the Dean of Life Sciences here at UCLA. And I've just, in thinking about what you just heard about the different groups that have come together to host today and who are in constant collaboration, I think when we think about the phrase, what does it mean to be one UCLA? I think this is what it means. It means that when you want to ask really hard questions and come up with the best possible answers and approaches based on science and based on understanding the communities that we serve, this is how that happens best. And so it is really an honor to be in this room with all of you and to be part of this exciting event. So it is my honor to welcome you on behalf of the Center for Reproductive Science, Health, and Education to the Distinguished Speaker Series. The CRSHE, led in the Division of Life Sciences and directed by Professor Amanda Clark and co-directed by Professor Hannah Landecker, operates in partnership with a number of units on campus, including the David Geffen School of Medicine, the UCLA Johnson Comprehensive Cancer Center, and the Eli and Edith Broad Center for Regenerative Medicine and Stem Cell Research. Recognizing the importance of reproductive health, the well-being of families, and to the benefit of society, the CRSHE was created as a unique opportunity to look at important questions on a national and an international scale. And it's a home for research, for training, and for career development, as well as public outreach in the reproductive sciences. So to highlight its impact, in the last 3 years since its launch, the center has funded 32 fellowships to support scientific research, has hosted a variety of classes offering hundreds of seats to undergraduate students to learn and participate in reproductive science, and it's launched its public distinguished speaker series where we can come together and learn from experts in the field and influential individuals who help us think about these important topics. And that is why we're here today. So for example, last year, as part of our distinguished lecture series, Supervisor Holly Mitchell was our first speaker who talked about Black maternal health. And so we're continuing the conversation about how do we think about and support all of our communities, not only in Los Angeles, nationally and internationally, thinking about really what are the fundamental questions that draw us together when we think about reproductive health. We are really honored to have partners here in attendance in supporting the center's work. So in addition to directors of the centers in the network of reproductive health and gender equity, which you've heard a little bit about, I'd also like to thank the Department Chair of OBGYN, Professor Christina Hahn, from the department's for the department's support of the series, Tom Rando, the director of the Broad Stem Cell Research Center. So thank you for your partnership, and we are honored to have you here with us today. So now it is my great pleasure to introduce our honored guest, Dr. Diana Ramos. Dr. Ramos was appointed Surgeon General of California in 2022. She is a visionary public health leader dedicated to advancing the well-being of all communities. Dr. Ramos champions efforts to address reproductive and maternal health outcomes, adverse childhood experiences, and mental health, which shapes policies that leave a lasting impact across the state. As an alumna of the Fielding School of Public Health here at UCLA, with more than 3 decades of experience as an obstetrician, gynecologist, Dr. Ramos has also held leadership roles across the local region, across the state, and across the nation. She is a recipient of the Latino Spirit Award and the Public Health Leadership Award. And so she has been a powerful voice in health equity, and we are honored to have her here with us today. So please join me in welcoming Dr. Ramos to the podium.
Thank you for that kind introduction, and buenas tardes, good afternoon. I am thrilled to be here with all of you and to be part of this distinguished lecture series. I'm so thrilled that so many of you are interested in this topic because it truly is critically important. Today, I want to talk about how early life experiences or adverse childhood experiences, ACEs, you may or may not have heard of them, are not just a mental health issue or a social issue. ACEs really are a reproductive health issue and a perinatal health issue. And if we address them, we can change the health trajectory of more than just one generation. We can change that trajectory for everybody that follows in that generation. Think of that opportunity for change, that opportunity to make a difference beyond that one generation. I want to start out by sharing a story, and this is a story of a friend. We'll just call her Lisa. That's not her name. Lisa is a very successful Black physician, married to a very successful Black physician. And I ran into her at a conference, and she was pregnant at the time. And I hadn't seen her. How are you doing? How is your pregnancy coming along? She says, I think everything is good. This was her 3rd pregnancy. I think everything is good, but I'm not sure. And I said, well, what do you mean? She says, well, Diana, do you think I may have a preterm birth? And I asked her, well, why would you even think about that, a preterm birth? And she shared, well, I had a preterm birth with my last baby. I thought, okay. So I started to ask more questions, always be curious. And I remembered, and in our conversations, I remembered that Lisa, just like myself, had grown up in South Central LA, had experienced a very difficult childhood in terms of the violence in the neighborhoods that we grew up in. There was a lot of violence, and really there was not much calm in growing up. Toxic stress. And little did she know, and then I put the pieces together, that it was that chronic toxic stress that she had experienced as a child that really set that trajectory for the disruption of her hormone levels, of the cortisol levels, of the stress that really impacted her genetic makeup, the epigenetics of her health. And it was that piece that contributed to the fact that she had health care. She was a physician. You would think she knew, right, what she had to do. But there was that one historical piece in her life that she could not change. And this is the piece when we stop to think about adverse childhood experiences and reproductive health that we need to stop and realize, wow, this is the unspoken knowledge, the unspoken awareness of where the opportunity for change and improvement can happen. And later on, I shared with Lisa and I said, well, are you aware of ACEs? And she said, no. And it was that realization that she then said, I need to learn more. I need to educate myself so that I can help break the cycles for others. So she went on to have her baby preterm. Her blood pressure went up. She had preeclampsia, and she ended up delivering preterm, the third preterm birth. So that is the hidden connection between ACEs and reproductive health. We have to remember what happens in childhood does not stay in childhood. It shapes our biology, our behavior, and our health outcomes across the lifespan. Just stop to think about it. And you may think of your past and think, well, that's the past. The change has already started. The change has already happened. So for those of you who are not so familiar with ACEs, just want to remind you that ACEs include experiences like abuse, neglect, household challenges in the household, like incarceration, domestic violence, divorce. All of these are household challenges. The original CDC Kaiser study found that 2/3 of adults had at least one ACE. If you're not familiar, you complete a 10-question questionnaire on ACEs, and that's what determines the level of toxicity or negative stress. 4 or more is negative. The study also found, though, that if you had at least 4 or more ACEs, you have increased heart disease, diabetes, increased risk for depression, and yes, complications in pregnancy. Wow. Now let's stop to think, right? Cardiovascular disease is the number one cause of death of all moms in California, no matter what your race or ethnicity is. So this is an opportunity to change that. There's a 44% decreased risk of developing depression if we address ACEs early on. So in California, under my office, addressing adverse childhood experiences as well as really promoting trauma-informed care is a statewide priority. It actually is in statute for my office. Now, because we look closely, ACEs show up everywhere in reproductive health. And what do I mean by that? Well, women with higher ACE scores, remember 4 or more is toxic, are more likely to experience unintended pregnancies, all right? They face higher risk of gestational hypertension, preterm birth, and postpartum depression. We're talking about trying to make a difference. It starts maybe with just looking at that upstream opportunity. And their babies, the babies actually have early biologic interruption and exposure of stress. Their epigenetic changes are happening in utero already before they're even born. So I hope you're starting to realize the opportunity of addressing adverse childhood experience, in particular in reproductive age people, because it makes a difference. And this is what we mean when we say maternal health is multi-generational, right? Because if we can help the pregnant person, you really are helping the next generation and beyond. So stop and think about that opportunity. Now here in California, we are uniquely positioned. Through my office, we have launched our Strong Start and Beyond program, which is our initiative to reduce maternal mortality. because we know that losing one mom is one mom too many whenever we have a new mom. We're bringing together the ACEs science with maternal and infant health policy. And policy can't be done alone. Policy is done with all of you. And I love the fact that you're all here from different disciplines, different backgrounds to come together to come up with a solution. This is where change happens. All of you at the universities, you ask the questions, you have the opportunity to challenge. This is where change happens, and you are those change makers. Now, my office has partnered with Stanford researchers and community organizations, and we look to see what is an opportunity that we can develop, what is an opportunity that we can implement. And one of those is PRIMA, our preconception medical assessment. So some of you may say, well, prima, isn't that the Spanish word for cousin? Absolutely. And we were deliberate in coming up with a name that resonated with Latino women. Because 48% of all of the births in California are to Latina women. So stop and think, all right? So we need to address the largest proportion in California of people that are having the babies. So we wanted a word that resonated with them. Prima, and if I can have the next slide, please. Prima is a 8-question quiz that helps people understand their chronic disease risk before pregnancy. And many of you picked it up, and if you haven't, please do so. And this is Prima. There are 8 questions that helps people understand their chronic disease risk before they become pregnant. It's a bridge between ACEs and preventive care, right? Oftentimes you hear, I didn't know that could happen. So Prima is a tool to transform I don't know to I'm ready, all right? I know you are all brilliant. You're here at UCLA, one of our nation's top universities. And I have no doubt that you researched, you studied, how do I get into UCLA? How many of you have even thought about your health, right? We don't think about our health. We have to think prevention. We have to think proactive. And this is what Prima does. So we're embedding Prima in apps, in clinics, in community spaces like nail salons, face centers. We are meeting people where they are. Because prevention, think about this, should never depend on privilege or proximity. It should be accessible to all. And this is what Prima does. So I challenge you, and I would ask you, my vision would be to put Prima behind every bathroom stall. Paste it, right? Because you have a captive audience there. You can complete Prima by the time that you are done and you started to think about, well, don't take too long, but you started to think about your health. That's what this is. Because you're not going to go to the doctor unless something is wrong. And Prima turns it around. So there are tips for everyone that are preconception, that are just stay healthy. If you don't want to get pregnant, you may want to think about using something that will help you plan. Or you may want to just get an annual exam. It just helps frame the information in a positive way. So please help me spread Prima. I know one of the initiatives that we are looking to do is with the sororities to make this part of their initiatives as their annual, I know you have to do a project. Let's do it, right? I see somebody, the Greek sweatshirt, AEM, even the guys can do this, all right? You guys can help us. Alpha Epsilon Meta, I'm not sure. But you all can help us. You are the future. So we are actually going to be releasing a digital widget so that you can put Prima on the website, on apps. We've got partners that have already committed to help us promote. Now, here at UCLA, like I said, you are helping us come up with solutions. All of you are being part of the next generation of physicians, nurses, public health innovators, beyond. And I want all of you to help us promote this. You're advancing, and I know there are researchers here, and we invited him. Dr. Paul Weiss is one of the researchers that we've partnered with, working on epigenetic research that shows how trauma and stress influence gene expression. The research is happening here at UCLA, and also showing how healing and connection, having relationships, having the ability of belonging to a group or to a family can reverse all of the bad things that have happened in childhood. So there are solutions for that. And you're providing the body, the reminder that the body remembers, but it can also recover, right? This is so critically important. So now imagine if every single one of you, I had a chance to meet with some of the students, the future doctors, the future researchers, the future public health leaders, if we all integrated the recognition of the importance of ACEs, of PRIMA in our health encounters, in the community, imagine the healing, the prevention that we can start to move from. We can connect families to support where it's needed before conception. So this is not just healthcare. This is prevention at its most powerful. This is that upstream approach that many of you who are in public health research are listening to and are realizing, wow, upstream, what does that mean? That means preventing the problem before it even happens, right? This is where the solutions can happen. But I want to share another story, one of Jessica. And Jessica was from San Bernardino County. And she lived through a lot of emotional abuse growing up. She had depression, anxiety. And when she became pregnant, her provider, who was trained in trauma-informed care, asked in a gentle, open questions about her history. And that was the one conversation that changed everything. She said, wow, doctor, nobody had ever asked me that question before about my past. And she was connected to counseling, prenatal care support, doula trained in stress reduction techniques. It made a whole difference for her pregnancy. She delivered full term, and she said, I was happy that I delivered a healthy baby, but more importantly, I was happy that I felt healthier physically and mentally after I delivered. This is the power of prevention. This is the power of addressing ACEs before, during, and after pregnancy. So it's not only about preventing death. I know when we think about maternal mortality is a rare event, but we have to prevent it from the very beginning. And this is one area we can do it. It's promoting whole person care, right? Whole person healing. Because we can't overlook the data, and the data drives action. And the nuances are that 80% of all maternal deaths 80% can be prevented. They didn't even have to occur. Over 80% of the heart disease deaths could have been prevented. They weren't even diagnosed. So I hope you're starting to see, wow, what's happening? We've got to prevent. We've got to identify. And by addressing ACEs, by looking at PRIMA, you're going to start that prevention mode. Remembering, too, that 1 in 3 women of reproductive age, 1 in 3 has a chronic medical condition already. So we need to take care of each other. California's Black mothers face maternal deaths 3 to 4 times higher than white moms. Again, the disparities, the data speaks for itself. And studies show that women with 4 or more ACEs, remember that's the toxic level, are twice as likely to experience pregnancy complications. So you're probably thinking, why didn't I hear about this before? Where do I go? When we connect these dots, ACEs, chronic stress, inequity, and perinatal outcomes, we see that maternal health crisis isn't just medical. This is not a medical issue only. It's a social, historical, and deeply human, right? This impacts us all. So to make the changes sustainable, we must integrate ACEs screening into all primary and reproductive health settings. The great news about this is that California already reimburses providers for doing this. If you have an MPI number, which is the ability to bill, social worker, nurse, midwife, physician, you get $29 reimbursement from Medi-Cal for doing an ACEs screening, for doing the right thing. We also need to continue training clinicians in trauma-informed and culturally responsive care. That training needs to continue. And we need to expand community-based support, the doulas, peer navigators, behavioral health teams. The beauty about this is that California already reimburses for this. California already has a plan to expand the doula care, to expand the healthcare navigators. So for those of you who think, I want to do something in healthcare, but I'm not quite sure, think about some of these routes. And technology. Technology needs to be used to connect patients with the resources early and before the risk becomes a crisis. I am thrilled, and I was sharing earlier, many years ago, I actually did the mHealth Fellowship here at UCLA that combines really mobile health technology with opportunities to change health outcomes. This is where change happens. And I do want to highlight, I don't know if Marissa Millwater and Ryan Clark are in the room. They're medical students. All right, they're in the back room. But these two medical students heard me speak at the OBGYN Grand Rounds, and I challenged the whole group just like this. And I said, there are solutions that can be hacked, that can be created through technology. And I said, I know there are people here who have experience in coding, in creating apps. And they surprised me. I got a call 2 months later saying, we have a protocol for what you were looking for technology. So you're going to hear big and bold news from them because my office will be promoting the work that they are doing. So all of you here, whatever your passion, whatever your interest is, you can use that to create the solutions. And the other thing that we need to do is to continue supporting the research on how healing interventions like mindfulness, counseling, and social connection improve the outcomes across generations. We know that, and that is happening already. My office partners with UCLA, UCSF to develop that research. So this is the California model. This is the one that recognizes that healing is prevention, right? It's not just a matter of here's a prescription or here, go see this doctor. It is let me help you prevent disease. Let me help you be healthier. This is California. So I have a call to action. For the UCLA students, thank you. Thank you for being here. Thank you for being the next generation of leaders, because by your presence here, you are hearing this message and you are already my ambassadors, all right? You need to remember that nothing is impossible. I know there were some of you that are saying, I want to be pre-med, but I'm not sure. No, you can do it. All right. There is no impossibility. Stay focused. Look at all the people around you. They want you to succeed. Remember, you will meet patients whose bodies tell the stories that their voices may not share yet. You can just see it. All right. It's been that stress, that chronic stress that really wore out on their bodies. And you may be the first person to ask, how are you really feeling? Remember to listen. We hear that so often. My doctor doesn't listen to me. My healthcare provider doesn't listen to me. But then it's not just the doctors, it's all of us as humans, because I can tell you in caring and speaking with senior citizen groups, with parents groups, I hear the same thing. My doctor doesn't listen to me, and that's from senior citizens. And from parents, my kid doesn't listen to me. My partner doesn't listen to me, right? And that's why we have 2 ears and 1 mouth, because we need to learn to listen. And to the professors and the clinicians in the room, thank you so much for mentoring and for being the leaders to really shepherd the next generation. They are our future, and I would encourage you not only to teach them about the science, about your specialty, but also to encourage the empathy and equity that is so critically important in being not only a human, but in caring. So I leave you with this final story about Maria. I met her in Fresno, and she was at a health fair, and she found out that she had high blood pressure. She did the Prima quiz, and she realized, wow, I think I need to go get some health care. And she did, but it was that small step, the realization that maybe I need to do something more, that made a difference. She said, when I got to my prenatal care, not only did I get the ACEs screening, but I was connected with specialty care because I was high risk. And she said, I never talked about my childhood. And she realized that it was talking and sharing about those experiences that really opened the door to her having a healthier pregnancy and getting the help that she needed. When we connect ACEs to reproductive health, when we listen before we diagnose, when we heal before we treat, we change the story for mothers, for children, and for California. So today, I ask each and every one of you to do one small thing to make a strong start for somebody else, all right? And it could be as easy as asking a question of, what can I do? You can post Prima. I would say I'll make that push. Because when we begin with compassion, connection, and science, we give every child, every parent, the chance to live beyond adversity. This is an us solution. So thank you, UCLA, everyone in this room, for your leadership, for your unwavering commitment to California's health and hope. Let's continue together in health. Juntos en salud. Thank you.
Thank you so much, Dr. Ramos, for those inspiring comments. So I'm now going to invite Dr. Ramos and Professor Amanda Clark, who's the director of CRSHE, to the stage. So we're going to start off. Dr. Clark has some opening questions for Dr. Ramos, and then we're going to open it up to the rest of you.
So at the CRSHE, we've worked very hard over the last few years to open this conversation to undergraduates, graduate students, pre-meds, medical students, to our stakeholders and partners at UCLA that think about different aspects of reproductive and maternal health so that we can collectively form solutions to some of these incredible pressing problems in today's society. And we're delighted that Dr. Ramos can be here to provide her perspective as well as part of our collective effort. So just to set the stage, in California, and I read this in some of your really important materials created from your office, that every 5 days a woman in California will die from a pregnancy-related event. So even though it is rare, is tragic and terrible. And so historically, when we used to think about pregnancy-related and associated deaths, it was hemorrhage and bleeding and infection, dying from infections. But now, in thinking about maternal mortality, the reasons why women die seem to have changed in the last 20 years. So do you want to talk a little bit more about some of the major reasons why women are still dying in childbirth today?
Right, so I mentioned it, so I'm not sure if it's me or...
It does feel very loud. It does. We're echoing at you, aren't we?
Testing? I think that's better.
Yeah.
So in California, as I mentioned, cardiovascular disease is the #1 cause of maternal death. And that is observed across all races and ethnicity. Part of the reasons is the fact that women are waiting longer to have their first baby, is the fact that there are chronic diseases that are present. 1 in 3 women will have a chronic disease. One of the most common is obesity. So when you have obesity, that sets you up for high blood pressure, for diabetes, and it just cascades and continues on. That's one of the most common reasons. I do want to highlight, though, that California has the lowest maternal mortality rate in the country. We have the lowest. And you mentioned hemorrhage. So back in 2004, 2005, California was the first to do what's called the maternal mortality review. So they looked at the deaths that were occurring in California, and they looked to see what was the cause. The California Department of Public Health was the organization that paid and asked for those results to happen. Once we had the information, the most common cause of death at that time was hemorrhage. And so California partnered with Stanford, and that's how the California Maternal Quality Care Collaborative was created. And what ended up happening is that we developed, and I say we because I was on the executive committee, we developed protocols to address hemorrhage. So you go through protocols, everyone goes through simulation, you just practice over and over again. And that, in collaboration with partnerships with all of the hospitals in California and with the physicians, the midwives delivering, that's how we changed that curve. And now the hemorrhage is the third lowest cause of maternal death. So that happened over and over again. So we started to have protocols for sepsis, protocols for hypertension. So this is how California has been leading. And this is what we're working on. But we have to remember, losing one mom is one mom too many. So when people ask me, why are you focusing on maternal mortality if California has the lowest? Because we can't lose one more mom.
Thank you so much. You've been a strong advocate for innovation and technology in healthcare. How are you engaging leaders in these industries to address maternal health challenges?
Yes, and this is the opportunity. And again, I am speaking, I know the young people probably have all of the apps and the AI, different platforms that you're knowledgeable, and it's wonderful. And there is a big disconnect with technology and healthcare, and it's not moving fast enough. It's not being adopted and led by those who are providing the care, right? And so I've had the privilege of meeting with many health tech innovators and connecting some of the visionary physicians, like in focusing on cardiovascular disease, with the companies that are really creating the solutions and now asking, well, heart disease is the number one killer of women also, right? We oftentimes think about it only as men. And so by challenging, by asking the question, well, how are you adapting this for caring for women? How are you adapting this in caring for pregnant women? And they stop to think, I never thought about that. No, well, let me introduce you to more thoughts so that we can connect and expand that. And this is the opportunity to really connect the innovation. If there's something that you see is working in one area, think about it. Well, how would this help in women's health? How would this help in reproductive health? There's no need to stop. We just need to make it better. And I love the diversity in the audience. Everyone's experience is so diverse that the solutions that we come up with will be so much better. And I mentioned that I did the mHealth Mobile Health Technology Fellowship here in this room. We met and they teamed us up. I was the physician and there were programmers and there were marketing people, social work people coming up with a health solution. And that's what you need. It's not just health, it's the diversity of thought and culture, because the solutions are going to be different.
So as part of our CRSHE fellowship program, we've funded a number of AI machine learning activities in order to better understand and predict maternal mental health, because that's also another big aspect of maternal mortality, is women who commit suicide during pregnancy or soon after as a consequence of this enormous life-changing event. And some of the data that has been very interesting to us is the idea that in electronic health records, the way maternal deaths are coded is different. So therefore, it makes it very challenging to create these very large machine learning models to create better predictive tools for physicians. So is there anything that your office can do in terms of helping to just simply better diagnose the code for when women are dying in pregnancy?
So that's what the California Department of Public Health Maternal Mortality Review does. And they have a whole team of experts from throughout California. You mentioned mental health. So 1 in 5 people have mental health challenges. 1 in 5 new moms have mental health challenges. And recognizing the fact that, yes, cardiovascular disease is the #1 cause of death. To your point, there is a high comorbidity, there's a high correlation association of there being mental health issues in addition to cardiovascular, in addition to hemorrhage as part of the causes, but it's not so easily teased out. So to your point, and this is something that for those of you who are coders, here's another challenge. You can easily come up with the protocol, the AI protocol. Just look at the patient's history if you have the medical record, right? If you have the medical record and you pulled, if someone had been on an antidepressant, anti-anxiety medication, and this is a new patient, it could be flagged, right? You can flag and realize many times patients, if they've been off it, they forget, oh yeah, I forgot I was on that medication. But here's the reality for mental health, is that you've had a snippet of what your future could look like. So in women, mental health in adolescence reflects on what's going to happen during pregnancy and what's going to happen in menopause. Anytime there's hormonal changes. So what I would often ask patients is, when I was taking care of them during pregnancy, how was your adolescence? Did you have any depression? Did you have any anxiety? And inevitably they would say, oh yeah, I forgot. You know, I wanted to kill myself. I was suicidal. So I am now alerting myself and writing a note, ask about mental health and during every appointment, because we know that if you've had one episode of anxiety, depression, you're going to have a higher risk during the hormonal changes, which is in pregnancy and then in the menopause. So it really is, pregnancy is a window to your future health. So people forget that. So to be able to use AI to leverage that history, and so even in menopause, okay, you see you're seeing somebody for an annual exam, and if it could flag history of depression in adolescence, in pregnancy, okay, this person, I can just do depression screening and see if they're having issues right now.
So I have one more question before I'm going to open it up to the audience. I'm just getting you ready so that you'll start putting your hands up. I actually wanted to bring Dad back into the room because there's a lot of interest in paternal mental health. And so not only is there such physiological changes occurring around the time of birth and bringing a new child home, but this new and emerging area of science about dad's mental health, thinking about these early adverse childhood experiences. If you have dad that's struggling when a new baby's being brought home, then this can contribute to the adverse experiences that you're talking about. So in your office, are you thinking about paternal mental health and how that can be incorporated into the roadmap that you're creating?
Absolutely, because for postpartum dad mental health, it's about 10%. Now, you just have to think of the general statistics. 1 in 5 people has a mental health issue, right? And you just do the math. And when you bring a new baby home, you don't sleep. So anytime you're sleep deprived, what starts to happen? Increased stress, increased challenges. Everything starts to unravel, or so it feels like. So the governor has actually had a new focus for all of the divisions, all of our agencies, to focus on men and boys. because it's so critically important, highlighting the fact that yes, mental health, we are all susceptible. Nobody is immune, and we have to include both men and boys. So we are working with partners to highlight opportunities, highlight programs that are working to help the dads. One partner in particular is Cura for Dad, and he has, and I thought this is a fantastic idea, it's called the fourth quarter for new dads. The fourth quarter to be able to focus on the dad, so that to help the dads after the baby's born, because I can tell you when my son was born, my husband said, that's it, I didn't know what to do. I felt like a chicken running around with my head cut off. I didn't know what my role was. And so the fourth quarter program focuses on the dad. It was created by a dad for dads to help dads transition not only to the new baby and helping their partners, but to help themselves as well.
Great, thank you. Okay, so now if you have a question for Dr. Ramos, we'd love for you to raise your hand. We have some microphones that are going to be moving around the room. So we have our first question over here. So we have 2 microphone runners, is that right, or just one? Two questions, yeah. That way you can do both aisles. And you'll need to state your name too, so Dr. Ramos knows who she's talking to. Yeah.
Hi, Dr. Ramos. My name is Nick Mouchouar. I'm a reporter from the Daily Bruin. My question is, how is your office addressing the challenges we've seen specifically to maternal health care that we're seeing in this current political climate?
So healthcare provision is through the Department of Healthcare Services. We live in California and are quite fortunate that the care for the mental health resources have already been created, and they continue to be available. One of those resources, and I would invite you all, go to calmatters.org. Calmatters.org is a fantastic website that is a one-stop place for all of the mental health programs that are available for free in California. One app that I would direct all of the students to is called Soluna, Soluna. Soluna is an amazing app that provides immediate support to whatever mental health challenges you have. It starts out with a chatbot because we know that many times young people don't want to talk to a healthcare provider. Maybe they'll talk to a friend, but you'll feel comfortable putting your life out on social media, right? Or on the app. So Soluna meets you where you are. Soluna, you go on there, you start that conversation, and it connects you to a healthcare provider if you need to go to that level. And there's one for the parents, and that's Bright Life. And Bright Life helps the parents help the kids. Because where do you start? I mean, for those of you, the parents that are in the room, you want to be able to help your children. And sometimes, as I oftentimes said when I delivered the baby, I wish I had an instruction manual to give you for that baby, but it doesn't happen. And so this Bright Life for kids is actually a resource that's available.
Thank you.
Thank you. Okay, so now the hands are being raised. So we're going to go over to this side. And I
Go
say,
ahead.
yeah?
So my name is Griffin Sanders. I am a first-year transfer in the Cell and Molecular Biology department. And my question is, so when you were talking about paternal mental health and adverse childhood events, are you focusing specifically on postpartum care, or are you also focusing on epigenetic alterations?
Everything, the whole spectrum, because there's an opportunity to, one, increase awareness across the whole spectrum, and two, one solution is not going to fit each stage of life.
Can you hear me?
I can hear you, and I can repeat the question for you. How's that?
Excellent. In thinking about PACEs, I don't know if it's ethical or not, or if it's, are there programs to promote retention, like people continuing in therapy? Because if you're trying to undo adverse childhood experiences and get people to rewire their brain, it takes a long, long time. And so are there efforts to make sure that people are continuing to stay in therapy?
So the efforts that have been already developed, and UCLA is one of those partners to my office, it's through the Children's Youth Behavioral Health Initiative. And that was a $4.7 billion investment to reimagine what behavioral health should look like. The thing that you should be aware of, and this is another website to go to, livebeyond.org. This is a website that was created by the voices of the community, young people, to talk about ACEs. Like, how long do I get passes? What are the solutions? And when I had the opportunity to meet with Dr. Vincent Filletti, Dr. Vincent Filletti is the lead CDC investigator for ACEs. And as a physician, I thought, wow, if I'm gonna do an ACEs screening, I'm not gonna have the ability to care for them, because I thought I'm gonna unravel a can of worms. And he said, Diana, this is a team approach. This is not for the physician to be the one leading that conversation. It's a team. And so what they did when they were doing the research is that they realized that people just wanted to talk. So he had the analogy of confession. He said, Diana, this is like confession. You know, people are holding it in their mind, in their body, and they don't let anyone know what has happened in their childhood. And it was when they talked about it, when they released what had happened, that was in and of itself cleansing. That's what he called it. And he said the best thing about it is that we invited them to come back and to continue the conversation. So the conversation in his office, and the research was done in Kaiser Permanente in San Diego, was really done by medical assistants, by social workers. It wasn't done by like super specialized healthcare providers. But he said it really was only 2 or 3 sessions that made the difference. So it wasn't, continuous talking and like, no, he said, the most important thing is to let the person talk. Let them say everything that they're carrying, and they're gonna be able to let it go and just start to move forward.
We have some questions in the middle area. So where's our microphone? We might have to bring it back over here.
Maybe if you stand up, they'll see
Yeah,
you, because-
yes.
Okay. Hello. Okay. Hello, Dr. Ramos. I am third year MCDB major. I'm also minoring in global health and specializing in computing. I'm Tahammul CRSHE, and I had a question regarding, we talked about programs and resources for the mother, for the father. Are there any for the kid? Because a kid growing up with parents that have ACEs can also develop, or is in the risk factor of also developing ACEs. So is there any resources or any programs available for the kid or the family itself, so it doesn't become a generational thing?
Yep, absolutely. And that's part of that Children's Youth Behavioral Health Initiative program. And if you go on the Live Beyond website, there are programs for the kids, for young people. It's free, accessible. The same thing with the apps. Those apps are meant to be part of that solution. Yes, absolutely. And then depending upon where in California you are, each county has received the funding to be used however they see is best for them. So I can tell you in Orange County, where I live, when my son was younger, there were parenting classes because I didn't know how to, I'm sorry, I'm a doctor. Yes, I can deliver your baby, but tell me how to be a parent, I don't know. And so there are parenting classes. So California, again, we're so fortunate to be in California. We also have the First 5 initiative, which is focusing on 0 to 5. 0 is pregnancy. How can we help improve the outcomes of our 0 to 5 children? And some of those are classes and instruction.
Thank you.
So this is unfortunately going to have to be the last question, but Dr. Ramos will be staying around afterwards, and there's going to be food outside. So who's got their hand up the largest? So perhaps over this side here.
Thank you so much for speaking with us, Dr. Ramos.
It's on. We can hear you.
My name is Gwendolyn Lee. I trained in internal medicine and I'm doing my fellowship in clinical nutrition. I loved how you highlighted the upstream impacts and highlighted obesity contributing to cardiovascular disease and maternal mortality. I was wondering if you could share more about your office's work in addressing food security, obesity, and general nutrition.
So in terms
Great.
of specifically nutrition, that is our sister agency, the California Department of Public Health Service. They have a whole, and I used to be the Assistant Deputy Director of Chronic Disease Prevention. And nutrition is one of those areas that is available through them. So there is extensive amount of work and programs that are happening already. And then I don't know if I can, the young man in the white T-shirt, if you want to ask your question. I feel bad.
that's so
I feel bad.
No worries. Okay, so hi, my name is Curtis Wong. I'm a current MPH MSW student focusing in the community health sciences. My question is, as you know, a lot of community members face a lot of medical mistrust, right, from negative prior experiences. So they may turn to community health workers, promotoras, or doulas as part within their local communities. I'm wondering, since you mentioned that California is looking to expand and standardize this work of community health workers, how can we continue to emphasize that, like, that trust and relationship building, especially in this new and developing system in the state?
So I would say use your lived experience, right? And we know that when the provider looks like the patient or the person they're trying to care for, that helps build rapport, that helps build trust. And know that there are programs already through, if you Google it, HCAI, HCAI, that are programs that will develop for those folks who want to go into a community health worker and then continue on to be I think it's a social worker and then psychologist, like they will pay. There's a whole trajectory of investment that is already being made. But I would just say, nothing without the community. And this is something that I have learned throughout my time in public health, nothing without us, nothing about us without us, right? We need the voices of the community to direct what they need and how they want it. And if you learn that, really, that early on, you are going to be much more successful instead of thinking, you know what they want, like, no, what do you need and how can I help you?
So Dr. Ramos, thank you so much for joining us today. We really appreciate that you took the time out of your extremely busy schedule to be here. So please join me in thanking Dr. Ramos. I know there are a lot more hands that were still raised, so please don't be shy. Dr. Ramos would love to come and talk to you, either here or outside where there is food, and please join us for the reception afterwards. Thank you again so much.